Hi, I'm Dr. Joe Rogers, and I'm the director of the Texas Heart Institute at Baylor College of Medicine. And I'm joined in the studio today by Dr. Hartzell Schaff, who is the annual recipient of the Fish Award, which is the award that we give for highest scientific honor at the Texas Heart Institute. We've been doing this for over 40 years. Dr. Schaff, we're so happy to have you here today. You give a wonderful lecture on helping us frame up how to think about how to quantitate mitral regurgitation and make decisions about interventions. And I thought it was just a brilliant lecture, but we've been so happy to have you here over the last 24 hours.
Well, thank you, Joe. I've enjoyed it very much, and I appreciate the invitation, and certainly it's been a great honor.
One of the things that we like to do in these segments is just try to take what we learned in Grand Rounds and make it applicable to people who are going back to the office on Monday morning and going to see patients with valvular heart disease in this case. And I thought you touched on some very important topics today. I think you made it through the course of your career. I think you've categorized this in such a way that you made it simple for us to understand, which was wonderful. I'm interested in exploring, I guess, a couple of things with you. One is, most of the cases that we talked about today in Grand Rounds were people that had relatively normal ejection fractions and had primary valvular abnormality. And you did spend some time talking about functional mitral regurgitation, but I'm interested in your practice over the span of an incredible experience. How have you begun thinking about and how do you make decisions about people with functional mitral regurgitation as the ejection fraction drops? Does it change the way you're thinking about this volumetric approach? And in your mind, have you set cutoffs below which you would say, I don't think mitral repair or replacement is going to serve this patient well?
Well, we didn't have enough time to discuss ischemic mitral regurgitation in detail, but that's a real problem and completely different than assessment and management of patients with primary degenerative mitral valve disease. And I think that the clinical situation that you described is a difficult one. For example, a patient might have heart failure and some degree of mitral regurgitation, present to the hospital or to your clinic with worsening heart failure and worse mitral regurgitation. Now, I don't think that the presence of severe mitral regurgitation in that setting is a trigger for an operation necessarily if you can improve their medical management, because the mitral valve leakage, functional mitral valve leakage, is so dynamic. However, if you treat the patient and get them down to a relatively dry weight, and they still have symptoms and an important amount of mitral regurgitation, and we can talk about what an important amount is, then I think the valve repair or replacement can improve their symptoms. I don't think the patient should come to surgery thinking that it's going to necessarily improve or prolong their life, and I think that's an important consideration.
I mean, I think that this is an interesting concept, especially as you began to draw in the percutaneous approaches to mitral regurgitation, because my sense is the same, and that is, we're not changing the underlying substrate.
Right.
We're actually correcting a valvular abnormality that's contributing to symptoms, but it's not the sole cause of the symptoms.
Yeah, Joe, I think that's a very good way of putting it. It doesn't mean that correcting valvular regurgitation is not important. And I think the whole field now changes because of the availability of percutaneous approach, although I'm a surgeon, and I certainly believe that a valve repair or replacement is a good option when it's necessary. But for the kind of case that we're describing, it makes sense to proceed with a mitral clip if that's possible. I don't know how to select a patient for a mitral clip in terms of the anatomy, but
and one of the things that we at least chat about in the back of conference rooms during some of these presentations of percutaneous approaches is the fact that it doesn't completely fix the MR, that there's some amount of mitral regurgitation. You brought up this idea of, whether someone should have a pop-off. I think that was one of the answers to one of the questions you posed. I mean, in people with more severe ventricular dysfunction, and if you're thinking about it volumetrically, is there any advantage to leaving a little bit of MR?
Listen, that is a very common concept, which I would call a misconception. Because if you turn it around the other way, if a patient comes in and their heart failure is worsening and they don't have very much MR, would you consider cutting a cord so they have a pop-off? And the answer is no, of course. So I think that the more complete that the correction is, the better off the patient will be. That's my bias. Although I do understand that if you went from a regurgitant volume of 45 to 20, that might make a difference in these patients that have marginal cardiac output.
Yep.
So that could improve them without completely eliminating the mitral regurgitation.
Yeah. We spent most of today talking about mitral repair. Does your thinking about this volumetric approach change in any way if you have to replace the valve instead of repair it?
There's lots of controversy among surgeons about the importance of preserving the chordal apparatus to the ventricle. Almost all mitral valve replacements done nowadays are done with preservation of the posterior leaflet. So that preserves the posterior cords, and I think we don't see the same impact on ventricular performance with a mitral valve replacement now that we did in the past. It makes a difference mainly in the problems with a prosthesis, not in the problems with ventricular function. That's the way I would put it.
And how do you integrate concomitant procedures? You presented a case where, or at least you talked about somebody who might have concomitant TR, or if you have to do bypass grafting. The patients are getting much more complicated, and they oftentimes are not showing up with isolated mitral valve disease any longer, but it's, you end up doing other sort of concomitant procedures.
Well, I'll get to that in a minute, but I think another situation is where you have both aortic and mitral regurgitation, because I can remember very clearly presentation of patients who said, I'm worried about the patient, the ventricle's big, but they only have a regurgitant volume in the mitral valve of 45. And I say, well, you said they had aortic regurgitation. How much is that? Well, it's only moderate. But if you add moderate to moderate, then all the ventricle sees is a lot of regurgitation. It's volume overload, which I think is an important concept and goes along with this volumetric assessment. So you don't have to have severe regurgitation of one valve if you have some dysfunction of the other valve. Now, the point I think that you were getting at was, how does the need for an additional procedure influence whether or not you repair the mitral valve? And I think that in coronary bypass surgery, that it's really much simpler than surgeons might let on. For example, if the patient comes to operation because they have unstable angina and they're put to sleep and the echocardiographer tells you that they have moderate MR, no leaflet prolapse, moderate MR, but the patient is coming for revascularization, I would probably not do anything to that valve because it's not going to improve the patient's symptoms or outcome. Mm-hmm. If, on the other hand, the patient has three-vessel disease, poor ventricular function, you think revascularization might improve the ventricle some, and they have regurgitation, but heart failure is an indication for surgery, I would correct the valve lesion.
And you touched on something else that I think is interesting, and it happens in hospitals all across the country and around the world, and that is the timing of assessment of mitral regurgitation. And so often we'll assess it in people in an echocardiography laboratory. It'll look bad. Get to the operating room, put them to sleep. It looks less severe. How do you think about that? Because I would guess that oftentimes you have to make a spot decision, especially if that's not the primary reason you're going in or you're doing a concomitant procedure. How do you integrate that, in the operating room and make a decision?
Well, again, the kind of patient that you're talking about is somebody with functional regurgitation, because this is not the same as with leaflet prolapse, which does not change very much with loading conditions. I think that we take that in consideration, but mainly the decision in my mind is driven by their preoperative symptoms. Patient's not on diuretics, patient has no signs of heart failure, and they have unstable angina. It's going to have to be torrential mitral regurgitation to make me do something to the valve, because there's a possibility that whatever I do is not going to make the valve better. And if they, for example, ended up with a valve replacement and all they needed was a coronary bypass, that's not a good outcome.
Yeah. Listen, if you didn't have a chance to watch Dr. Schaff's Grand Rounds, I would encourage you to watch. It was really a brilliant discussion today of mitral regurgitation. And Hartzell, thank you so much for joining us in Houston, and congratulations again on being the 2025 recipient of the Racy Fish Award.
Good. Well, thank you, Joe. I've enjoyed it very much.
Thank you.